Good morning, ladies and gentlemen, dear guests, dear colleagues, Minister of Health, Mr. Viļevičs. It's a real pleasure to start our first session. My name is Ģirts Briģis. I'm coming from Rīga Stradiņš University. I'm head of Department of Public Health and Epidemiology. And because of my work tasks, which are related to epidemiology and health policy, I have honor and also pleasure and responsibility to chair this session. And the title of the session is Strategies for Promoting Healthy Eating Habits, Physical Activity, and Reducing Inequalities Among Children and Young People, Data, Research, and Initiatives. According to our scenario, first of all, I would like to invite speakers on stage, and please, Mr. Philippe Roux, take place on stage. Then Dr. Agis Tsouros, Dr. Joa Breda, Dr. Michele Cecchini, and Mrs. Ilze Burkevica. So, our first speaker is Mr. Philippe Roux, representing the Directorate-General for Health and Food Safety, European Commission, and head of the Health Determinants Unit. Mr. Roux is going to speak about European Union policy and strategies to tackle childhood obesity. The floor is yours, Mr. Roux.
Thank you. So just as said, Mr. Minister, dear colleagues, you can imagine it's for me a great pleasure to be here. When you read the title of the unit I'm responsible for, the Commission Health Determinants. So really having an event by the Presidency on the issue of the health determinant is for me something I find very important, as you can imagine. What I will try to do rapidly is to give you an idea on how we have translated the last 7 years into a sort of reality with the member states, the strategies that we agreed together at the time, and in a way allowing us to take stock at the beginning of the conference so that at the end of the event you can have an opportunity to build on what you already have achieved with us, which I think is very important. So, as was said by the Minister, my director, and the colleague of WHO before, the challenge before us is terribly high. In a way, as I was saying, I'm trying to talk of the reality. We have said that there was an increase in childhood obesity among young people. One element I could possibly share with you of reflection is that we have improved our capacity to measure. So let's cross fingers and let's say that the situation, thanks to the COSI experiment, which looked really at the reality of childhood obesity by measurement, show us the exact reality. So in a way, we know now what is the challenge before us. It's also true that we are in a situation where we have never been as sedentary as we are, and where we are all have been parents at one point or in another, and we can see that children are less and less active, and it's particularly worrying in adolescence. And my director was talking about inequalities. There was also an interesting inequality here, which is that we see that young women are definitely less active than young boys. So there is already very early different type of inequalities we are facing when we try to develop the policy. I say that because it means, as a first conclusion here, we can't have a one-for-all solution. We need to really define a set of elements that will be the complete approach that we can work on. As was said before, and I think this is something we need really to not only say, but really take account in what we develop in terms of strategy and approach. The reason why I say it is because very often we are developing new strategy and new ideas without having checked whether they are potentially increasing equalities or not. And I have witnessed in my career a number of bad good ideas, which indeed are the result of increasing inequalities among the different groups. But we need to look at the cost of the burden of the diseases we are trying to tackle, and also of the measures that we are taking. As I said, and as my director said before, the gradient of obesity is very important as an element, making, for me, more and more important that whatever we develop, we focus on inequalities. I'm sorry to repeat that, but that's very important that we have that in mind during these 2 days of reflection. What we have done in the Commission and with the Member States over the last 10 years. First, I think what we have developed, and which I find a model which is rather solid in terms of mean to develop a comprehensive approach, is to work on the one hand with the Member States and with the Member States authorities to reflect on first the health objectives we want to meet, and second on how we want to engage with all the stakeholders, and to also engage work with the civil society, and in particular with those actors that can contribute to the solution. And that means including the civil society as a whole, so from the health organizations to industry. And that was exactly what was in the heart of the strategy we adopted in the Commission in 2007. And you will see that the theme of today was already back in 2007 a central theme, because we considered already at that time that, yes, of course, overweight and obesity is an issue for all, but it's in particular an issue with the young people. Because one thing that science proved already is that overweight at young age or obesity at young age quasi-ensure obesity at a later stage. So as I said, we developed work with the Member States in what we have named high-level group. As it is time to take stock, I want to repeat why we said high-level group at the time. We wanted to have a high-level group because we considered that if you want to act as public authorities on issues that relate to nutrition and physical activity, it's an imperative necessity to have someone from the health department that is at a level that he can engage conversation with his counterpart in the other ministries. Because you can't achieve anything if you're unable to discuss with your agri counterpart or with your tax counterpart. So, high-level group on nutrition and physical activity. And I have to say that I'm very proud having been the Sherpa of this group for a number of years, because this group had created a number of impulses at an EU scale. My director mentioned before the action plan on childhood obesity that the high-level group endorsed last year, which is an important piece of work to many respects. First, because it is something that was built by the member states themselves. And second, because it gives a potential for action that will help developing good practice across the Union. But they also did a number of other initiatives which are perhaps less known. Things that they have already in 2008 worked together to achieve a common agreement on objective to reduce salt, in a process which was very interesting, which was at the same time a process led by national authorities, but also giving space and work for the stakeholders. So here, in practice, a comprehensive approach. We have also had this experiment, which is, in fact, it's a year of anniversary for the Commission, for me, and in a way, because it's 1 year from the action plan on childhood obesity, but it's also 10 years of functioning of the platform for action on diet, physical activity, and health. It was from the start the concept of a voluntary approach. We have now 33 members covering a vast majority, I would say, of the stakeholders that can have an impact on childhood obesity. And since 10 years, we have more or less 300 commitments. I know figures means nothing because I think a couple of the commitments that are there cover the entire Europe and have had a very important impact. Some others were smaller. So it's not so much the size, but what are these commitments that made a difference? I decided to choose one which may be for some of you as Member States Authority representative a bit controversial. The one on which is known as the EU Pledge, which is a commitment on responsible advertising. But it gave me an opportunity to make two important statements. First, as this conference focused on school and on children, that already in the strategy in 2007, schools were considered as protected environment, and they should remain so. So that's the first element. The second is that this pledge is an interesting example because it first resulted of an EU law. So there is a directive on advertising that the member states have agreed on. And in this directive, it was made very clear that the role of the Commission was to promote self-regulation. So in a way, when I'm asked questions by colleagues, why don't you do a regulation? It was because the regulation stated we had to promote self-regulation. So it's for you now to think whether this approach was or still is the right approach. But that is your take. But on our side, we have done what the regulation foresaw. And more importantly, for this example, I think it's a very good example because you have seen that the pledge has evolved 3 times over time. And I mention it because it was very important, because the platform allowed also a dialogue between industry colleagues and the consumer protection organization and the health organizations. And really they have evolved in terms of reducing what they could advertise. And also to the point that now the pledge in its mature version has also taken into account a set of profiles as reference for what can be or what cannot be advertised. So I think industry took serious in the context what we asked them to do in terms of not advertising under 12 and to take responsible path on what they can advertise. We have a number of tools that we have put in practice, and I know that there is a stand somewhere in this bibliotheques, and I invite you to go and see what we have achieved on, through the health program. It's a modest program. Well, we learned recently that they are even more modest program because there was a program on sport and physical activity, which is less than the health program. So my director was pleased to note that we were not the smallest, but it remains small. But even so, it gave us the opportunity to give the right push to a number of initiatives at European level and to create a reasonable mass of good practice. Also, as I said here, we have tried also to take our baton and to go through the different services and to work with other services, this famous health in all policy dimension. And for that, what we have done, for instance, is to develop close relation with our colleagues in DG Agri. And that resulted in an improvement in the approach of how fruit and veg should be distributed to schools, and how that project could pass from a simple project of recycling of excess of fruit and veg to something which is more an educational process, where you don't only distribute fruit and veg, but also you create the condition of a sustainable consumption after the distribution. We also worked very closely with our colleagues in charge of sport and culture. And you certainly know well the Council recommendation on promoting health enhancing physical activity, and the guidelines that have been produced by experts and now are diffused around Europe, and we hope are serving as a base for more action. And we continue that focus on physical activity in the coming years. We also developed work with our colleagues of DG Research, because as you well know, we need to be able to understand the phenomenon to better act. It doesn't mean that we need to always wait for having the results of the research to act. I like to say, start fast and improve, and I think that it is taking the risk of developing new policies, and that it's also important in our reflection of these days. But research is important, and I think the Commission made a number of important efforts to ensure that we cover the wide range of the elements that should be considered to develop a right policy. Up to 4 sites exercises looking at different scenarios in the future to try to see which type of response would lead to which type of result. We've worked also a lot with DG Connect, and in particular for the Audiovisual Media Service Directive I mentioned earlier. So it's our hope that we'll have an opportunity to rework it and improve it. In areas also that may not at glance seems to be the most important, like for instance looking at the role of new media, because the law that we have is possibly well for the situation 10 years ago, but today the situation is totally different, and with the new social networks, the connected TVs, so there is a number of elements that are not covered by the current regulation, so that needs to be looked at further. Also, we have invested more and more into the Joint Research Center, not only because it's one of the Commission services, so it's a pool of researchers that are at the service of the Commission to help us forging and backing up the policy that we are trying to put in place, but also because they are able to provide us rapid response on the work that we have in particular with the high-level group on nutrition and physical activity. They, for instance, very topical for this 2 days event, they have produced interesting guidelines on school meals. And they have done an interesting mapping on what exists in the different member states, and I recommend it as an interesting reading for you. Very close to the last, the Parliament. I could not finish my presentation without mentioning the support that we received from the European Parliament. And in particular, they provided us means to look at different experiences to not only trying to help ensuring a higher consumption on fruit and vegetables, but also to try to do it before specific socioeconomic groups, so those most at needs. And it's my hope that the result of these will come with interesting results that can be used and transferred in other regions in Europe, where we have people at need. We also looked in this pilot project to pregnant women and lactating women, having understood that because science showed how much this is a period that forges also the taste of children later. So very important also area. So here again, we hope that the pilot project developed will help us seeing which are the best approaches. Now for the future, and this is 2 minutes. The future, and the future will be forced by what you will do of it in a way. First, at least for the Commission, it will be to look at what we will have been able to achieve through the action plan on childhood obesity. And we are working closely with WHO to ensure the monitoring of the activities there. It will be also important for us to see how far we can progress with the joint action that my director mentioned on nutrition and physical activity. But in 3 words, and keep that in mind. Our commissioner recently met the stakeholders, high-level group and platform members, and he said 3 elements which are important that was already mentioned by my director before. First, inequality. Whatever we do, we need to think of inequality and be pragmatic, not to say, oh, well, we need to think about it. No, we need to act about it. So whatever we do has to have an inequality reduction angle. He also mentioned food reformulation as an angle that can go across the board. So yes, if you look at the achievement with the platform, with the high-level group, we have gone, I would say, well, we're here in a city with an interesting bridge. Between here and the whole city, there is a bridge. Let's go on the other side of the bridge and let's do more. So which means that we need to focus on that and do more. The Commissioner wanted we do that. He also mentioned important element cooperation, and as was said before, to help us being able to better profile the situation in the member states, because the discovery we had through the recent research was that there are differences not only between the member states, they are not rich or poor member states, but they are rich and poor regions. So therefore, we need to think of tailoring the answers to the differences within the member states. Therefore, we need to build a better capacity to map the situation. Thank you very much.
Thank you, Mr. Roux, and definitely it's obvious that the European Commission has recognized this as a problem, and certainly strategies are involving a joint action not only among countries of the European Union, but also, as you mentioned, stakeholders, different, and sometimes with very different interests. And certainly, the European Union has a vision and how to tackle, and there exists ongoing programs and also as well plans. Thank you about that information. Next speaker. Next speaker is a representative from another very important organization, which is World Health Organization, and speaker is Dr. Agis Tsouros. a Director of Policy and Governance for Health and Well-being, and Mr. Tsouros also deals with a program which is very well known in Latvia. This is Health 2020, and also is heads of Center for Urban Health and Governance and the Healthy Cities Network. Topic and title of speech will be political choices and supportive environments for healthy living.
Thank you. Mr. Minister, dear colleagues and friends, I'm very pleased, I'm delighted in fact to be here with you. And I would like to start by bringing you the greetings of our regional director, Dr. Susanna Jakob, who is our director for the European region of WHO. I've been to many conferences. I've been to many conferences over 20 years plus, where the issue of chronic diseases is addressed. And I ask myself, what is different now? We keep talking about diet and smoking and lifestyles and risk factors and physical activity for years. We've even been talking about healthy public policies, integrated approaches, good monitoring, and so on. Why do we keep talking about it and not doing enough about it? What is different today? Well, today I would like to say that we are overwhelmed by the evidence we have. We have a much better understanding, not only of which are the risk factors or which are the conditions that create circumstances for people to become chronically ill, for people to adopt unhealthy lifestyles. We understand the determinants of health. We understand the causes of human behaviors. We understand much better this complex interplay between environmental, genetic, social factors that in the end have such a big impact on the way we are, on the way we lead our lives. We have also understood much better today what are the solutions that work, what are the interventions or the combinations of interventions that can make a difference. We understand much better the role of fiscal policies today. We understand much better the role of supportive environments. Yes, we go back to the Ottawa Charter back in 1986. We were talking then about something that we keep forgetting today, which is that healthy choices must be the easy choices. You cannot just continue to blame the victim. And I can say this with certainty, 30, 40 years on in our public health history in Europe and worldwide, we keep making the mistake of thinking that sometimes that the individual is either a passive recipient of forces operating around them and unable to do something which has more control in their lives or better ways of living, or we think that the responsibility on the individual overrides any other influence on their choices. The truth is somewhere in between. So today, we are asked to understand much better the context within which we try to make the changes. That's why we talk about the political determinants of health. That's why we talk about the commercial determinants of health. And we have, therefore, to be able smarter today, because the evidence is there. The political will, as never before, is there, not only locally or nationally, but also globally. The global community now is alarmed by chronic diseases. We are alarmed going on the beach during the summer looking at our children getting fatter and fatter. We have to do something about it. But what we have to do cannot just be in name tackling chronic diseases. I'm sorry to say this, I'm no longer impressed when I'm told that here is a policy or a strategy dealing with chronic diseases. I'm no longer impressed when I'm told that our aim is to have our children leaner and healthier. Because it's no longer the what, it is the how you are going to do it. Are you going to use 20th century approaches, or are you going to use 21st century approaches in dealing with health, public health, and also chronic disease? There is this issue of individual responsibility. Individual responsibility is important, but in the context of the influences that a person is subjected to, without understanding the social context or addressing the social context, is very difficult to attribute individual or personal responsibility for choosing an unhealthy lifestyle. Sometimes then we look at the other end. What is our social responsibility? Is our social responsibility limited only to providing access to our best services, to our citizens, to everybody? Or is it more than that? Is it not to be able to understand those influences that shape the behaviors of our children, of our young people, of our adults, of our older people, and doing something about it, understanding that social context that has a huge impact on them. Also, sometimes it is dangerous when we look at people as just subject to receiving information that they have to use, and if they don't, somehow they could be held morally responsible. Yes, there is a moral responsibility for all of us as individuals when we know that resources are scarce, and living in a society where we are struggling to sustain our health systems and the resources for sustainable development, yes, we all have a moral responsibility to be healthier. But we have as a society a responsibility, especially to our children, to create the preconditions that will lead them to have more control. And I'm going to use a term which is very important today in the context of this conference, health literacy, to be more literate. We have to create individuals and institutions that are health literate. Health literacy is no longer what it used to be in the 70s, just knowing what is good or bad for your health. Thank you very much. We know that. I know many people are very excited by the prospect that today everybody has a device and they can get all sorts of healthy messages. But it's not enough to tell people what is good or bad, children or older. We need to have something more than that. We need skills. We need to understand to navigate a complex world. There are many traps out there. We need the political will. We need to know at what level to act. I keep hearing, for example, that physical activity is a must. And then I get into discussions where we all talk about sports. Sports are crucial. Stadia are crucial. Gyms are crucial. But we have to understand that physical activity is not only about those settings. It is where we live. It is our neighborhoods. How walkable are neighborhoods? How we can, as a father or as a grandfather, I can take my child safely to go for a walk in a local green. But I would like to be able to do it in every part of my city, not only in the more prosperous parts. I want walkable streets. I want proximity to the local shops. I want to be able at work to go up 5 flights instead of taking the elevator. Our healthy living, our active living is not only about sports, it's about a way of life. And if this way of life is not created everywhere to make it easy, it will never have the impact we expect. The same with nutrition. We can preach until the end of the world what is good or bad, less sugar, less salt, less this, less that. But in reality, it is the proximity. It's to be able to have choices that are easy. Sometimes local leaders have taken, as you know, upon themselves to create such an environment, sometimes at great political cost. There is a role for everybody here. We have always this dilemma, as I said before, between the personal responsibility, the social responsibility, and human rights, the freedom of choice, sometimes the cost of choice that we have to afford as a society. Today, we know much better what are the forces at play when we talk about the political determinants of health, because it is naive as public health practitioners to think that in our town, in our country, or in our Europe, or in the global world, that there is harmony. In fact, if there is something that we can do in our nations, at least when we talk about intersectoral action for health, is to promote not just coordination, but coherence, policy coherence. Let's not have one sector going in that direction and another sector in another direction. Let's have common societal goals. What is a more formidable goal than a healthy start in life, than investing in our children? As you probably know, WHO concluded with Michael Marmot and a team of 80 experts around Europe, the European Social Determinants study. The first and most important goal is about children, creating those preconditions, but not in a traditional way. Let's find a way to talk with the ministries of education, which is much more than talking about healthy meals at schools. There is much more that we know now, based on the determinants of health, that can enrich, that can make this dialogue with other sectors much more meaningful. Health in all policies, it's not just talking about the negative consequences of other sectors' policies, is finding those win-win situations. Why is it a cycling lane something that can benefit energy, traffic, environment, health, you name it? Those co-benefits are very important in understanding the determinants of health. So I would like to conclude by saying that today the evidence is there. We are swimming in evidence. We have to be smarter in addressing inequalities and determinants and behaviors, and especially the social environments that reproduce those, especially inequalities. I will even argue, I cannot imagine that we can talk about personal responsibility when a society does very little in addressing social determinants and inequalities. It is a matter of good governance for health, it's a matter of vision, it's a matter of understanding that investing in the health of our children will make all the difference into the further development of our society. So I would like to wish us that, since we know what works today and we know what makes the difference, that we will make that qualitative step towards introducing policies at all levels of government and also at European level that actually take full advantage of this amazing evidence that we have today to make a true difference. Thank you.
Thank you very much, Mr. Tsouros. And this is really very interesting and important point you raised. This is about a level of society, of when people are thinking and producing policies together at the individual level, and the challenge is to join vision, social vision, and this individual approach. And this is really very interesting and challenging, and thank you for raising this very important topic and question. Next speaker is also representative of WHO, Dr. Joe Breda, and representing programs for nutrition, physical activity, obesity, non-communicable diseases, and health promotion division at the WHO. The topic Dr. Breda is going to talk is tackling childhood obesity, WHO strategies for promoting healthy eating habits and physical activity for children.
Thanks, Chair. Good morning, everybody. Honorable Minister, friends, colleagues from DEC, member states, and all others. It's really very nice to see so many familiar faces, but also good to see that we have new faces that I've never seen before. It means that the field of nutrition and physical activity is actually managing to capture more interest and more people than to go out there and implement our ideas and the initiatives that we think are really critical and very important, as it was said before in, I would say, very inspirational fashion. So what I would try to do during my presentation is basically, while sharing with you the mandate that WHO has been given by the member states and our governing bodies to work together on this and try to identify certain areas that are more specific for the school setting and some of the elements where we actually think we can together do a bit more. We all have, very strong calls and powerful mandates in terms of what member states and society expects both from the European Commission and particularly WHO at the European level. Our mandates are very clear, they are strong, they are renewed, they were not there before, and they are very recent. So there are no doubts that there is a huge big interest from different sectors that actually WHO and the European Commission should and have to work together in terms of fulfilling those commitments. And those commitments, they are clear, and in a way they are very pragmatic. We've discussed together and we've found ways to, transform this visionary kind of approach to something that is tangible and actually allow us to, take effective actions in a relatively short period of time. And I'd like just to remind us all that, by having a European framework in terms of public health, Health 2020, that Dr. Tsouros just highlighted some of the most, I would say, important elements of this policy as the inspirational element for everything that is done in public health. In Europe, clearly the Vienna Declaration is a result of trying to look at, this Health 2020 in a new way, trying to have a perspective that includes the issues of governance, leadership, the whole of society, and health in all policies approaches. And clearly a very, practical outcome of these important frameworks is obviously the new Food and Nutrition Action Plan, for which the Vienna Declaration gave WHO the mandate to work with the member states in order to achieve that, and as it was said before, the future physical activity strategy. We also know that, in the Vienna Declaration, it was really a political document where clearly member states gave WHO the indications that we really need a renew of the different nutrition policies, and at the same time, for the first time, a physical activity strategy. We sometimes complain about what the European region is doing, but I would also like to convey a positive message that the European region is actually leading the way in many areas and is being very innovative in some other areas. But actually the first region of all the WHO regions to have a specific physical activity strategy. And this is happening now. So member states clearly said, okay, we need to renew the mandates, we need to work on diet and nutrition, but we really need something specific and a physical activity strategy, which is again inspired by Health 2020. So we really did receive that clearly mandate, and we've been working quite intensively with the member states in the last 2 years in trying to achieve that objective. So really, vision is very important. And the inspiration from that vision, which has to be ambitious, we really look for a Europe that is, if possible, free from the negative impacts of non-communicable diseases, particularly those that are linked with diet and physical activity. And although this seems like almost unachievable in the forthcoming years, it is important that we keep it as our vision for the future. And it is important that we together do everything we can that is in our powers to really make sure that we try to implement that vision. So normally when we read documents, we kind of, jump over the vision, but the vision is clearly probably one of the most important elements. And we believe that the Food and Nutrition Action Plan is very strong in this dimension, in this area. So it's at the same time very pragmatic. Member states wanted to have 5 priority areas. One of them is trying to create healthy food and drink environments. As it was said before my predecessors, we can't just talk about individual responsibility when the environment is so difficult. And when society and when economies actually are, working based on, demand, offer and demand, and that's really, tremendously important. We have to be aware that any policies that affect, for example, sugar production or anything that is part of the food system certainly is going to have an impact. And we have to be realistic that it is important to affect food and drink environments. Health through the life course, and clearly, identifying children as a vulnerable group and, a group of individuals that need a special attention. Reinforce our systems, acknowledging that we're probably not doing enough. I mean, it's commonplace to say that 50 to 70% of health professionals in Europe are not enough trained or properly trained in the fields of nutrition and physical activity. We don't have the necessary professionals even in the health systems. Therefore, we also need to put our own house in order. And there's clearly a gap there. We've all together identified that. Not going to, talk too much about surveillance. You've seen few people talking about some of the very innovative initiatives that we have in our region, particularly looking at childhood obesity. And this can only work if we work in using, frameworks and really in ways that promote leadership and good governance. And we also have some examples of that in our region, very innovative initiatives, as it was said and was mentioned again by my predecessors. So really focusing on intersectoral action, 5 priority areas, very pragmatic. A short list of recommendations. So there are a few recommendations by each priority area. And there is an attempt to try to identify tools, instruments, and other elements that can really help member states to implement. We need the vision, we need all the guidance, but we also need, elements that facilitate implementation at the national and local level. And that is something that the Food and Nutrition Action Plan clearly calls for. And of course, we are evidence-based and we need to be able to collect, all the available science. But as it was said before, there is a point to which it is enough to take action based on the science that we have, and we can't wait that much. So both Vienna Declaration and the Food and Nutrition Action Plan really try to bring together within these 5 priority areas the importance of health systems, monitoring and surveillance, intersectoral action, healthy environment, and of course, the very critical element, which is your need to develop a policy, but you need to implement it, and furthermore, you need to evaluate that. And we find sometimes some difficulties in some member states, and actually in some circumstances, we really don't manage to cover the full cycle, and that's really very important. When it comes to schools, this Food and Nutrition Action Plan and the future physical activity strategy, there are a few elements and series of examples that member states can uptake in terms of implementing their initiatives. And there's clearly mention of, elements that are considered important, notably mandatory standards for schools, we think, and they are included in the action plan, and we believe that they are important. What do you do in terms of the nutrition education and the school curricula? What do you do? How do you go about the provision of foods in schools, not only about the school food scheme, but also others? And how do you operate all of this together? Are we all convinced that schools need to be spaces fully protected from the pervasive impact of marketing of foods that are too high in fat and sugar and so on and so forth? So this is clearly included as part of the Food and Nutrition Action Plan and are given as examples that member states could really uptake. And why do we need this? We need this because we really have a problem. We're improving our data. There are areas where we still need to fine-tune and really get better in terms of obtaining the necessary data, notably in children under 5. But if you look at the existing availability of data from countries, you really see that, even before entering into primary school children, the prevalence of childhood obesity is already very important. And we continue. We're trying to, get our data better. And it was mentioned before, I'm not going to explain again the slide that Dr. Gali already talked about. But by having this capacity, where we are able to monitor and we are able to look at the trends. This is again, a slide looking at the COSI data, and you can see that we have good and bad news. We cannot be assured about the trends at the moment. We already collected data 3 times. We're working on the data from 2013 and collecting data again in the school year 2015-2016. But you can see that in the countries in the south of Europe, who actually are the ones with the highest prevalence, there might be a chance for a leveling off or a decrease. But at the same time, in the countries in the north of Europe where we have lower prevalences, there might be kind of a tendency for an increase. So, eventually different trends and eventually different realities, but the data is highly comparable. Countries collect data in a very systematic fashion. It's highly harmonized. Even the scales, I always like to say that, are the same. There's no other region of WHO that has such a system. It involves more than 200,000 children. That's really useful, I would say. A lot of countries are involved. And the same situation more or less for girls. Again, you seem to have a tendency for a decrease in the south of Europe and eventually a little bit of an increase in the north of Europe. More and more countries with an interest, now more than 20, negotiating and discussing with some other, particularly some big member states in the region, which are not part of COSI yet, but new countries like Austria, Poland, Slovakia, Croatia, possibly Denmark and others will soon join. So our dream is to have 28 countries from the EU in this COSI, and I think that this is really the result of a good collaboration with the European Commission. Of course, you've seen that one. We have the capacity to look at inequalities. And of course, we also need to consider the dimension of physical activity. That's really, striking that the physical inactivity in adolescents and children in the European region is really, really very high. So the percentage of children and adolescents that reach the minimum levels, as you know, is 60 minutes per day, is really something that we need to take in consideration and work together both in terms of promoting diets but also physical activity. When we look at the mix of policies in countries in terms of looking at the actions around preventing childhood obesity in Europe, this slide is just to share with you that there is an uneven distribution at the different areas, the different policies, different levels of implementation, and therefore there is a lot of room for improvement and for better implementation in terms of if you want to have some impact, you really need to be more sophisticated in terms of what you will be doing. Of course, what can you do in schools? We can do a lot in schools. In schools, you can really influence the environment. Children spend most of their day probably in schools and really have the obligation to provide not only better food, but also better education in terms of diet and physical activity. This one needs to be highly sophisticated, and we need to practice what we preach. We can't just theoretically talk about within the curricula healthy diets and physical activity, but then we don't create the environmental situations that really promote physical activity in schools. So being very practical, replicating, enlarging, successful initiatives like it was said before, the school fruit schemes, but there are others. And we have to be creative. And we have very good examples in very many member states in the European region, whereby taking action, comprehensive action, multi-sectoral actions, actions that involve different partners, that involve different areas of programs, you can really achieve success, even in the short run, in preventing childhood obesity. So it has been done, systematic reviews, analysis has been done in terms of what works in schools, and we kind of know what needs to be done. And when we look at the progress, actually, all countries have some kind of policies. Some countries are doing better than others. And it's very useful what the JRC has done in terms of looking at the school policies. And, some countries are being eventually more brave. They are taking, more steps. They are being faster. But there is really a lot of hope so that, we all acknowledge that schools are very important. And we all acknowledge that, we need to take a comprehensive approach, not only in terms of delivery of information, but really, looking at the different dimensions. A lot of things to do in terms of physical activity. I'm not going to repeat what was said before. It's not just, for sports. It's creating the opportunities for children to walk to school, making, creating opportunities for them to have spaces where to play, extracurricular activities. The physical education in schools is really striking that, we're in the phase where probably sugar consumption is going to increase in Europe in the forthcoming years, and we're in the phase where member states are reducing numbers of physical activity hours in schools. So we're talking about policy coherence, but we need to do more together, as was said before, because policies don't really seem to be very aligned in this context. But the good news is you can change and you can achieve results. It's just an example from my own country. Sorry to bring this one about, but it's, a multi-sector intervention, different components, multi-component programs, doing the right things. You can really reduce BMI in, a few months. So it's really a lot of hope. By looking also at the Childhood Obesity Surveillance Initiative, we're also looking at the environment in schools. And we kind of develop a score where we could eventually, I wouldn't say classify schools, but before I finish, just to share with you that within the same country, and 11 countries participated, we've seen that within the same country, you have schools that do very, very well. They have very comprehensive, very nice, school food and physical activity, approaches, but other schools that actually don't do so well. So that's a huge variability when you try to compare countries and within countries. So there's really a lot to do in terms of improving this, in terms of the, and almost finishing. So high variability, and in some schools, really the environment is really poor in terms of what we are doing in terms of nutrition and physical activity. So in summary, very good progress, guidance, regulations, school fruit schemes, food in schools being more up on the agenda in many instances. So I think we need to be optimistic, but we can do better, particularly in some countries and some schools, we can really improve and really push everybody up, I think. So, but better foods and more physical activity is really important. So just the theory and the information would not work, so we need to work using probably, nutrient profiling tools, using, guidance, using, improving the curriculum, but also creating the opportunities for more recreation in children walking to schools, and so on and so forth. We need more data, but with the data we have, we know what to do, and we know that we should be doing it. And that heterogeneity and scarcity of data shouldn't stop us really from moving forward. Thanks very much.
Thank you for Mr. Dr. Breda. And really, WHO is doing much, and everyone knows that huge efforts regarding empirical basis for health problems and particularly obesity as well. And certainly still we need more and more data and more accurate, not only about prevalences but also determinants. And what was interesting also to hear about different new initiatives regarding more strategic, more structural approach in policies. And also certainly there is still a lot to do for European region as well. Next speaker is representing another organization, and this is Organization for Economic Cooperation and Development. And Dr. Michele Cecchini is an economist and policy analyst at the OECD Health Division. And Mr. Cecchini is going to talk about improving lifestyles, tackling obesity, the health and economic impact on prevention, and the floor is yours.
Mr. Minister, representatives from member countries and other international organizations, dear colleagues and friends, I'm delighted to be here today with you all to provide inputs from my organization, the OECD, to the debate that is happening here in Riga. We believe that child obesity is a top health priority for Europe. I don't want to spend much time on analyzing data with you. When I saw that before me were speaking three experts from the WHO, I was sure that they would provide all the data we need to highlight how big is this issue for Europe and more widely for countries. Let me start just one data. In this case, 21% of children in OECD Europe are overweight or obese. Of course, there are also big differences across countries, and in some countries we have almost half of boys that are overweight or obese and 40% of girls that are overweight or obese. As one of the topic of this high-level meeting is on inequalities, I wanted, although, to present some of the data of the results of our analysis, in particular for two EU countries, France and England, in terms of inequalities within country by level of income. And children living in families that are disadvantaged are up to 2.5 times more likely to be overweight and obese. Now, I'll ask you to concentrate, to focus a little bit to better understand this graph. We take as a reference the most affluent quintile, which as a risk of 1 of being overweight or obese, and then you see that moving from the left to the right, you have least affluent quintiles with the dark red and blue bars as the most disadvantaged groups. And you see that consistently there are trends, and the risk of being overweight or obese increases as the quintile of income decreases. So, for example, in France, the children in the least affluent quintile are 2.2 times more, have a higher risk of being overweight and obese, and children almost 2.5 times. Very similar results are also, can be also seen in England. Countries in the European region and worldwide have experienced a few years ago, and in some cases are still experiencing the effects of the economic crisis. In May 2014, at the last European Conference on Obesity, I present results of the just published at that time 2014 OECD Obesity Update, in which a special focus was given to the effects of the economic crisis on shifts of healthy behavior, on diet in particular, but also on physical activity in OECD countries. The results of our work show that recession have have exacerbated unhealthy behavior in vulnerable groups, more in vulnerable groups than the rest of the population. Here, for example, you have some of the data we put together for Italy, and during the first quartile, the first quarter of 2014, we saw a decrease in food expenditure compared to before the crisis of almost 2%. This decrease in expenditure was not equal across the different kind of dietary nutrients that people could buy, but our analysis suggests that people shift from more costly per calorie nutrient towards more cheaper and usually unhealthier products. For example, decrease of fresh fruit and vegetable decreased by 4%, of fish decreased by almost 8%, while low-cost food increased by almost 3.5%. Another effect that we saw is that financial crisis is increasing inequality in obesity and health. Of course, when we talk about family, we also should put children into the equation. And in particular, we know that food insecurity and decrease in food expenditure is associated to a higher 22% probability of child obesity. Let me open also a parenthesis. I know that the main focus of today is diet and physical activity, but there are studies. There is a study that OECD is going to publish in terms of alcohol consumption, and a focus will be also given, provided on children. And alcohol also is a component of the equation of unhealthy nutrition and is one of the driver of calorie consumption. And our result, and here I will ask you some attention to understand these four graphs. We have boys on the left and girls on the right, and age at first drink on the top, the two top graphs, while first episode of drunkenness in the lowest two graphs. And some of the results that our analysis suggests is that people, children, are initiated into drinking at a much younger age than they used to be. And also the first episode of drunkenness happens in almost more than 40% of boys, and the same for girls, when they are less than 15 years old. So when, according to a law of the majority of European countries, they shouldn't even be drinking. And there is, as we are talking on inequality, another quite scaring, I would say, effect. There is a decrease on inequality, but a decrease of inequality I think we shouldn't cheer for, because girls are catching up with boys while girls in the past tend to have lower initiation of drinking and episode of drunkenness. Now they have comparable, very similar levels to boys. Going back to the main topic of today. One of the duty of the OECD is to help policymakers in shaping better policies for better lives. So when we started the work on obesity in 2006, health ministers that gave us the mandate to work on this asked us to provide an answer to very clear questions that they had in mind. Does prevention improve health? Does it reduce health expenditure? Is the value for money of the policies that we aim at introducing in our country good? What we need are effective and efficient policies, cost-effective policies. Do they decrease health inequalities? And then, in particular, when will desired effects show up? We carried out analysis, a comprehensive set of analysis for a number of countries. In particular, today I'm showing you results for Western Central Europe, what WHO names Euro A region. I must say that we are now undertaking a major refurbishment of our modeling approach, and we plan to produce a new series of analysis taking into account more nutrients, extending the range of nutrients that our analysis takes into account, in particular particular, this set of analysis was mainly focused on level of physical activity, fruit and vegetable consumption, and fat consumption in countries of the Western Central Europe. And here we have some of the result of the average returns in terms of health, mortality, and disability-adjusted life years that this set of policy may produce. Policies that are dark-shaded, so food advertising, self-regulation, school-based intervention, food advertising regulation, are specifically aimed at children. Policies that are more light-shaded are aimed at either the whole population or, at people aged more than 18, while we have food labeling policies and fiscal measures that have an effect also on children. And here the fact we have is that I have a good news for you today. Prevention does save life. In some of the most effective intervention, we could gain 1 life year every 12 to 10 people. But also intervention that affect children may produce significant results in terms of both reduction of mortality and reduction of life years. Now, if you look at just at this graph, perhaps you may think that intervention targeted children may be less effective than other intervention. And one of the reasons is that in this specific case, we have an average return over the studied period. When we go to look at this longitudinally, we see that we should expect that the intervention targeting children, and in this case I'm presenting result for England, of a series of intervention, and in particular food advertising intervention regulation for children, you see that the effect in terms of mortality, and in this case is disability adjusted life year, is tend to be smaller at the beginning of the implementation. And the simple reason is that if you look at healthy life expectancy, you don't see big changes in children when they undergo the intervention. Most of the diseases that we address by tackling diet, physical activity, produce a change in mortality down the line, when people are 40, 50. So you have to wait that these children that undergo the intervention become eventually adult and experience a lower probability of dying because of cardiovascular diseases or cancer, for example. If you focus instead of your analysis on more proximal indicators, level of obesity, for example, but also insurgence of some diseases, development of some diseases like diabetes, you would see that results show up at population level much before than this graph. However, even just looking at this graph, you see that in the medium-long term, intervention targeting children produce an effect on the life expectancy, on the healthy life expectancy of population, which is comparable and in many cases higher than intervention focusing on the whole population. The effect on decreasing health inequalities for school-based intervention is excellent. According to our result, we see that school-based intervention have a greater effect on individuals in lower socioeconomic group. In particular, on average, school-based intervention have effect which is 40% higher on individuals from the lower income groups compared to individuals from higher income groups. And here on the right, you have some of the effect on the population in Western Central Europe by socioeconomic status. In particular, the red bar is people with low socioeconomic status, while the light blue bar is for people of high socioeconomic status. And you see that independently from the age group you're looking at, but the exception of 91, for people aged more than 91, the red bar is significantly higher than the blue bar. That means that school-based intervention provide a higher effect on low socioeconomic status. Now, if you want an idea of the kind of school-based intervention we modeled, a good example comes from the EU School Fruit Scheme, which takes many, although not all, the elements that we implemented in how we modeled our intervention. In particular, our intervention was included the elements of the EU School Fruit Scheme, but included also a component on physical activity, which is not necessarily implemented in the EU School Fruit Scheme. this European-wide policy target children aged 6 to 10. In some countries, it reaches people also in the high school. Children are offered fruit and vegetable, and an important feature that we saw, according to our analysis, may make the difference is that it's not just offering of fruit and vegetable, free usually, but this is put together with other side activity. For example, farm visiting, gardening, extra hours of information about how important it is to have a healthy diet. And in fact, this is also put together with an educational component, for example, provision of pedagogical kits, which is pretty often included. As the focus of today is on inequalities, some analysis carried out in 2010 showed, and this is an important feature, that similar effectiveness is provided to children in different socioeconomic status. Not all the policies that we assessed are able to provide the same kind of effect on people with different low socioeconomic status. So potentially, this kind of intervention may decrease health inequalities in the European population. One of my last substantial slides is on public-private partnership. Public-private partnership, as all the partnership, may provide both challenges but also opportunities. And I think there are some good examples that we can take from outside Europe and may also help Europe in moving forward on public-private partnership. I thought Philippe Roux, for example, earlier on, told us how comprehensive is the approach that European countries are having in terms of public-private partnership. And I wanted to present you today an example from South Korea that introduced a multi-stakeholder approach with the aim of reducing trans fat in child food. The way this public-private partnership was shaped is particularly interesting because it put together collaboration between the industry, university for the reformulation of food, research institute, and government. The content of trans fat was aimed at reducing, and in particular, the legislative part included a compulsory labeling of the content of trans fat on the top of child food products. The government, and in particular a special agency of the Korean government, provided also support for research and development to the industry. What happened is that in a relatively short time frame, the production of food aimed at children, in particular, for example, biscuit, chocolate, snacks, presented a substantial decrease in the content of trans fat food. My last message for you is really the takeaway message from my talk today. Child obesity is a top health priority. Less well-off children suffer the majority of the burden. Prevention is an effective and a cost-effective way to improve population health, decrease health expenditure, and improve inequalities. Intervention targeting children are effective, but produce results in the medium term, if we focus on healthy life expectancy in particular. Comprehensive strategies combining action on different targets, target group, provide the best results. Multi-stakeholder approaches have challenges, but also offer very good opportunities for moving forward on this crucial topic for Europe. Thank you very much for your attention.
Thank you very much. And certainly, OECD has also very good experience regarding data collection and data analysis, and particularly it's very good to add that certainly Latvia is on a stage of becoming a member of OECD, and also I noticed you included also Latvia already in your analysis. So thank you for that, and certainly we did hear that again, research, knowledge is a very good and essential part for creating policies and also become more effective, and also especially to stress in cost effective as well. Thank you very much. Several times today we hear the word inequity, and certainly this is a very important topic and very much related to obesity problems and child obesity. And now I have a possibility to give floor for the next speaker. The next speaker is Ms. Ilze Burkevica, and Ilze is representing European Institute for Gender Equity, and she is a statistics officer. And I have a temptation, I would like to also mention that Ilze is a graduate of Riga Stradiņš University and bachelor program of public health. The floor is yours.
Thank you, Chair. Good morning, ladies and gentlemen. Good morning, Mr. Minister. As I was introduced, I'm coming from European Institute for Gender Equality. So I will present a slightly different topic. Well, topic could be the same, but slightly different approach. It will be more measurement and statistics based. My presentation will be about looking at health from a gender perspective. Although gender equality is a fundamental value of the European Union, enshrined in its treaties, it is not yet a reality for men and women around Europe. Measuring gender equality through an index was initially proposed by the European Commission's roadmap for equality between women and men, and subsequently integrated in Action Plan of Strategy for Equality between Men and Women. And IGE, European Institute for Gender Equality, took this task of developing Gender Equality Index already 4 years ago. So the first index was launched back in 2013, and it will be updated this year. About the European Union health strategy, how it comes. The European health strategy, of course, is a key pillar of the Europe 2020 strategy as achieving smart, sustainable and inclusive growth in the economy requires a population in good health. It relies on two approaches. The first approach is investing in health, which aims at spending smarter but not necessarily more, investing in sustainable health systems, investing in health promotion initiatives, investing in health coverage, and inclusivity of health systems. The second pillar is Together for Health, strengthening coordination and cooperation across the European Union, and complementing national health policies and work towards improving public health. Putting together how gender and health comes in EU policy. So we refer back to Roadmap for Equality between Women and Men and Strategy for Equality between Women and Men. They both highlight need for adapting the specific needs of women and men to a greater extent. Now I will talk a little bit more how we measure health aspects in Gender Equality Index. The first task when developing Gender Equality Index was to clear direction of what is the purpose of gender equality. There are many contrasting ways in which to address this purpose, and the challenge was to draw the main elements from different approaches existing, without losing the essence of concept of gender equality. So what the European Institute for Gender Equality did, we took that equal share of assets and equal dignity and integrity between women and men is the one what we want to measure. Subsequently, the Gender Equality Index measures gender gaps for both women and men, but adjusts them for levels of achievement. In this way, we are considering also the context of each member state. So the Gender Equality Index is obtained when individual indicators are compiled into a single measure. So we are taking a multidimensional concept and putting it together. In other words, we are describing a complex reality by aggregating together different concepts in a meaningful way. For that, what was needed was to develop a conceptual framework. And this is the structure of our Gender Equality Index, and it presents elements that are combined and that are calculated in together. The Gender Equality Index consists of 8 domains: work, money, knowledge, time, power, and health. And it has 2 satellite domains: violence and intersecting inequalities. And domains themselves are divided more detailed in subdomains. This is for morning maths. This is our formula, if you would like to practice a little bit during the coffee break. And Gender Equality Index is a synthetic measure that measures how far or how close in the European Union and its member states are in achieving the gender equality 4. So the measurement shows that the range, how it's showed, is that 1 stands for inequality while 100 stands for full equality. After 50 years of gender equality policies being integrated in EU, still the average score in European Union is 54. The range of member states starts from 35.3 for Romania and highest is 74.3 for Sweden. But still there is a large room for improvement for overall in European Union. The challenge in the area of health is to ensure that needs of men and women are met with levels of achievement. In gender equality, gender equality is raised, decreasing gaps, and because it's directly linked with economic independence, dignity, and integrity. So the domain health in Gender Equality Index contains 3 aspects: status, behavior, and access. Due to data availability, we couldn't take into account in calculations health behavior. Health status has 3 indicators: self-perceived health, life expectancy, and healthy life years, while access has unmet needs of doctor and unmet dental needs. Overall, the scores of Gender Equality Index for health domain, only for this part of the Gender Equality Index, shows that gender equality is quite high, having 90.1 percentage point in the European Union in average. If you remember, the overall index had just 54. However, the majority of member states has reached a score above 3/4 towards equality, with Netherlands having 94.7, UK 95, and Ireland 96. At the lower end, there is Latvia with 77, Poland with 82, and Hungary with 83. Gender gaps combined with high levels of achievement in the domain of health present overall a picture with high score for gender equality in member states. About the part which we could not calculate in this time in Gender Equality Index, behavior part. There are several data sources available in the European Union, but we considered European Health Interview Survey because that is harmonized and comparable data that will be available on a regular basis, probably every 4 years, but now it's also discussed that it could be every 6 years. But for this purpose, for this presentation, we used data which were collected between 2003 and 2006 in previous round of European Health Interview Survey. So we considered variables which are measuring height and weight, physical activity, consumption of fruits and vegetables, smoking, and alcohol consumption. As you can see, obesity rates as measured by body mass index range from 8% of population in Romania to 23% in Malta. Women are more likely to be obese than men. For example, in Latvia, 21% of women compared to 12% of men, and Estonia as well, 21% of women compared to 16% of men. In another EU member states where obesity is measured, gender difference tend to be smaller or not so visible. About physical activity by sex, over half of population practices daily physical activity. And in the majority of the member states, for which data are available from European Health Interview Survey, men have higher levels of physical activity overall, with an extreme 72% of men involved in physical activity in Czech Republic compared to 55% of women. The only exception is Greece, where women are more involved in physical activities than men, 61% compared to 52%. About fruit consumption. The consumption of fruits once a day or more varies across different member states. In Belgium and Bulgaria, less than half of population consumes fruits at least once a day, compared to 3/4 of the population in Spain. Without exception, women are more likely to consume fruits at least once a day. If the difference is small in Austria, 62% of women and 59% of men, it reaches more than 20 percentage points difference in Germany. Overall consumption of vegetables at least once a day is slightly higher than for fruits, ranging from 51% in Malta to 85% in Belgium. Gender differences are less pronounced than with fruits, although with the exception of Bulgaria, women are systematically more likely to consume vegetables once a day or more. Another, this time unhealthy behavior, cigarettes. In the member states for which data are available from the health interview survey, between approximately 1 in 5 and 1 in 3 individuals smoke cigarettes daily. Women are without exception less likely to smoke than men, with gender differences that can be very important. In Latvia, for example, 13% of women smoke compared to 46% of men. Binge drinking. Around 2/3, or about 9 out of 10 people overall in member states for which data are available, do not engage in binge drinking. Binge drinking is when 6 elements of alcohol are consumed at once. While a great majority of women do not engage in binge drinking, and it is high overall at 80% around the European Union, the situation is very different across the board for men. The difference between women and men starts at 11 percentage points in Spain, but exceeds 30 percentage points in Romania, Slovakia, Slovenia, and Czech Republic. If we look at these data which I presented a second ago, and in comparison with Gender Equality Index, we can see quite interesting results. We use the same methodology in calculating these data in relation to the Gender Equality Index as we would do if we would calculate the index themselves, but however, for methodological reasons, currently these data are not included in the Gender Equality Index. And as you can see, that for countries that are higher scores of consumption of fruits, vegetables, and non-smokers, also are associated with higher scores in Gender Equality Index. The same stands if we look only at the health domain of the Gender Equality Index. So the countries who have higher scores for fruits, vegetables, and non-smokers are positively associated with the scores of domain for health. And what we can conclude? In summary, taking into account the gendered behavior of women and men, particularly when it comes to fruit and vegetable consumption, as well as smoking, it is very much related to gender equality more generally. This demonstrates the importance of considering the area of behavioral health in measuring gender equality. It also shows that there are consequences for the measure provided by the Gender Equality Index, which was thus far unable to measure health behavior. From a policy perspective, focusing on health needs to be done in a more inclusive manner. Health is gendered, particularly when it comes to health behavior. It also shows the relevance of paying attention to the extent to which women and men are engaged in a healthy lifestyle. Thank you very much.
Thank you for Ilse Vurkavica, and today we learned that there is a very effective tool to measure gender inequality index, and certainly this could be used also for policymakers to measure inequalities and also to base policies on empiric and good statistical data. Thank you for that, and we have finished with our reports. Unfortunately, we, according to our schedule, we don't have time for questions and to discussions. We have to postpone those things. But next, I have to announce press conference, which in minutes will take place where? In 11:45. We have to be back here for the next session. Details maybe Egita will provide.
Thank you, Chairman.
We
are going to add 15 minutes for our coffee breaks, and we should return precisely and 45 minutes after 11. Be precise, we have a very interesting and tough agenda ahead. And for officials, there will be press conference just now. So please enjoy your coffee.